This lecture is going to cover disorders of the nasolacrimal system as well as how to correct them. The next series of slides will cover nasolacrimal anatomy. This is a schematic of the nasolacrimal duct and sac overlying the face. There are puncta in the upper and lower lids that drain to a vertical canaliculus of about 2 millimeters. This then transitions horizontally to a horizontal canaliculus of about 10 millimeters, and there's often a common canaliculus before it enters the nasolacrimal sac. The sac sits in the lacrimal fossa and then becomes a duct as it drains down into the nose. This is an outline of the bony orbit. The lacrimal sac, as it enters the duct, sits in the lacrimal fossa, which sits between the lacrimal bone, number 3, and the maxillary bone, number 4, in the nasal orbit. This is a cutaway of the lateral nasal wall. As you see, the inferior turbinate is removed, and the small dot just underneath this is the opening of the nasolacrimal duct. So as you're probing into the nose in the operating room, you're going to be going along the floor of the nose posteriorly and laterally to encounter the tip of your probe. This is a cadaveric specimen showing similar anatomy of the lateral nasal cavity. The probe is entering the opening of the nasolacrimal duct under the cutaway inferior turbinate. There are a number of developmental anomalies in the nasolacrimal system. The first we'll discuss is punctoatresia. These patients present with tearing but no mucus, as there's no reflux from the nasolacrimal sac. There's usually just a thin web of epithelial material over an intact canalicular system. These can be dilated with either a sharp dilator or a pin in the operating room. You may put a stent across to make sure it doesn't heal back over. The second anomaly is a lacrimal fistula. These often happen in the presence of nasolacrimal obstruction, where you develop an epithelial-lined tract from the lacrimal sac to the skin. These patients will have tearing through the side of their nose. These often will close with resolution of nasolacrimal duct obstruction, but you may require excision of these with closure with a suture. May occur in the setting of congenital nasolacrimal duct obstruction, especially if there is a one-way valve at the common canaliculus. These have a number of names, either a dacrocystocele, a amniocele, or a blue dome cyst. The swelling is below the medial canthal tendon. It's thought that because of a proximal distal obstruction, mucus is retained in the sac with a swelling of the nasolacrimal sac. It requires probing early on to prevent any infection with stagnation and to prevent dacryocystitis. If you do get dacryocystitis, the patient is going to require systemic antibiotics, as the orbital septum is not formed fully in the youngest patients. Here are two clinical photographs of patients with dacryoceles. The upper left has a rather large one, displacing the lid up and in, and the picture on the right side of this slide here shows a typical bluer coloration of these dacryoceles. I have one patient who had something that looked like a dacryocele similar to this, but actually on CT scan was a hemangioma. So be aware of that in the differential as well. If a dacryocele goes uncorrected, they can get infected, and the top left picture has a rather injected area over the lacrimal sac, and the bottom right has bilateral dacryocystitis with ulceration of the one on the right side. Nasolacrimal duct obstruction is one of the more common surgical procedures in pediatric practice. Nasolacrimal duct obstructions are present in approximately 5% of infants, and many of them resolve spontaneously, usually by 6 months to a year of age. It's usually due to a membranous obstruction at the valve of Hasner, where the duct enters the nose, and this leads to epiphora as well as mucoid discharge, because the tears that are forming as well as the mucus from the sac cannot enter the nose. They back onto the eye. The differential in patient that is tearing includes punctoatresia, conjunctivitis, blepharitis, as well as glaucoma. You can confirm the diagnosis with the dye disappearance test, where you instill some fluorescein in nasolacrimal, instill fluorescein in the tears and wait to see how long it takes to disappear. Two patients with the typical clinical appearance of patients with nasolacrimal duct obstructions. There's epiphora as well as mucoid discharge bilaterally in the upper upper left-hand picture, and on the left eye of the lower right picture. In younger patients or patients who have parents who are hesitant about surgery, there are a number of non-surgical options that may help patients with nasolacrimal duct obstructions. Topical antibiotic drops or ointment can be used if the patient develops conjunctivitis due to stagnation of the tears. Some parents will want to try digital massage over the nasolacrimal sac to try to increase hydrostatic pressure to cause a rupture of the obstruction. When you're planning surgery for nasolacrimal duct obstruction, there's a number of considerations preoperatively. You might want to consider the patient age. If they're less than 6 to 9 months, you may be able to swaddle them and do in-office probing without the need for anesthesia. Patients that are older than 36 months of age probably have a decreased success rate with simple probing irrigation and may require either balloon dacryloplasty or nasolacrimal intubation. Other complicating factors can include prior surgery. Down syndrome tend to have a more sinuous nasolacrimal duct. Facial trauma can have bony obstructions or fractures of the nasolacrimal duct, and any bleeding disorders the patient may have. My usual procedure for probing and irrigation of patients is to dilate the punctum, pass successively larger Bowman probes in the nasolacrimal system until you can't pass them through the punctum any longer. I then can confirm patency in a number of different ways, either with direct visualization of the probe tip in the nose with an endoscope, metal-on-metal contact with a larger probe passed underneath the inferior turbinate, or recovery of fluorescein stained fluid with aspiration. During surgery, you might want to note the level and type of obstruction. Is it a simple pop at the valve of Hasner, or something that's more proximal? Is there multiple obstructions? Is it a very tight nasolacrimal duct? Usually you want to cover the patients with antibiotic steroid drop for 4 to 7 days following surgery to prevent healing of the opening that you've made. So here's a diagram of the steps of surgical procedure. This diagram is showing probing through the upper punctum. I tend to go through the lower punctum. It's a little bit more of a straight shot, and it tends to be a little bit wider. Patients or surgeons who prefer probing through the superior punctum say that if there is a false passage, they still have the lower punctum to go through. My advice is just not to create a false passage. Once you go through the vertical canaliculus, you'll then pull the lid laterally and extend across the horizontal canaliculus and into the lacrimal sac. You should feel a bony obstruction, or a hard stop as you touch the nasolacrimal bone. Once you do that, in diagram B, you're going to turn the probe vertically and go down the nasolacrimal duct. It tends to be directed inferiorly, a bit posteriorly and laterally as you go. Panel C shows direct observation with a speculum, or placing a second probe in for metal-on-metal contact to confirm patency. I discussed a few of the tips on the previous slide, but things to really watch for is preventing a false passage by applying lateral traction on the lid. That's the way you're going to make the vertical and horizontal canaliculus a straight shot. If you do get a soft stopper, the lid starts bunching in front of your probe, stop, reassess the situation, pull back some, pull the lid taut, and advance again. Once you get to through the obstruction, you're going to be reaching the floor of the nose, which is the roof of the mouth. Try not to push this into the palate. If you're going to be irrigating, prevent a large amount of fluid, because the fluorescein can cause the patient to go into laryngospasm, especially if they're not intubated by the anesthesia team. An adjunct procedure to nasolacrimal probing can be inferior turbinate infracture. I think this tends to go in and out of favor in our circles. If the inferior turbinate is impacted on the lateral nasal wall and there's really no room when I'm doing metal-metal touch, I'll push the inferior turbinate nasally or medially with a large probe to create an infracture. You can also do this with a hemostat. If a patient complains of a lot of functional symptoms, meaning they get a lot of tearing discharge when the nose is congested, sometimes doing an interior turbinate infracture will help with those symptoms. You want to pack the nose with either Afrin or cocaine to create some hemostasis. You can either put a hemostat under or across the intermittent and rotate it nasally. In the very young, you can obstruct the airway, so you want to be careful in these patients. Here's two anatomical pictures of the inferior turbinate. Upper left picture, the blue shaded number 2 is the actual inferior turbinate. And if you look straight on into the nose, you'll see the inferior turbinate coming down like a scroll. This is important to kind of keep in mind as you're passing a larger probe into the nose to try to get metal contact under this. You want to be nasal, you want to be along the floor of the nose, and progress posteriorly. If you're going to infracture, you want to get either the large probe or the arms of the hemostat between the inferior turbinate and the lateral nasal wall, and then push it immediately towards the septum. When I first started practice, I was doing a significant number of balloon dacryoplasties. It was a fairly simple procedure that was very similar to a probing with a balloon at the end of the probe. It tends to take longer at this point than for me to intubate, do a nasolacrimal intubation. It's also more costly. So the procedure is similar to probing, but the tip of the probe has an inflatable balloon. It's similar to cardiac angioplasty or coronary angioplasty, and expands either 2 millimeters or 3 millimeters depending on the patient's age. This allows you to bypass the diameter limit of the punctum. With simple probing, you can only put a large enough probe that will fit in the punctum. With the balloon, you can put a deflated balloon across the punctum, then blow it up inside the nose to a much larger diameter. The procedure involves a manometer. We inflate the balloon to 7 to 8 atmospheres for 9 seconds, deflate it, reinflate the balloon for another 60 seconds, then you pull the whole system back 5 millimeters and repeat the process. Typically, I had been using this if they failed an initial probe or they were older than 18 months, but again, I haven't done a balloon dacryoplasty in probably 5 or 6 years and moved straight to nasolacrimal intubation. Here's a schematic of the lacquer cath in place. Again, they've gone through the upper punctum here and pass it down into the nasolacrimal sac and into the duct. The probe goes the whole way to the floor of the nose. You inflate the balloon twice and pull it back 5 millimeters and inflate it twice again. Practically, this is what it looks like in the operating room. The probe is in the surgeon's left hand here into the nasolacrimal duct, and the right hand is holding the manometer. You twist the knob to increase the fluid pressure inside the balloon, and it expands in the lower two pictures here. In the patients who are older or have failed initial probing, I've moved almost exclusively to nasolacrimal intubation in these patients. There are two types. You can have a bicanalicular intubation, which is either the Crawford system or a Monaca system, or a monocanalicular intubation with a Monaca probe. These tubes tend to stay in place for 2 to 3 months while the healing process takes place, and you can remove them in the office. If the patient has unusual circumstances like Stevens-Johnson syndrome, you can leave them in longer. I've had patients that have had the tubes in for up to 6 to 9 months before we remove them. This is a surgical photograph of nasolacrimal intubation on the left side of this patient with a Monaca tube. The difference between a Monaca and Crawford tube is that the Monaca is swedged onto a proline leader, whereas the Crawford has a semi-rigid metallic probe. The Monaca system goes through this Rittling probe shown here, which has a hollow core that allows the proline to slide down into the nose, and you can recover it. I think the recovery of the proline leader on the Monaca is less traumatic than trying to recover the metal Crawford tube and bending that out of the nose. The Monaca system is actually fairly interesting in that the initial part of the proline leader is thicker, and then the area that's closer to the tube is actually thinner and allows it to come out of a small opening in the side of the probe once you place the tube in place. And you can see in the bottom photographs it just peels right out. So you'll recover the end from the nose, you'll pull the Rittling probe back and slide it over this thinner piece of the probe, and then pull it all into place and have the tube go down through this nasolacrimal system. The recovery of the proline leader in the nose is actually fairly easy. Once you have the Rittling probe advanced the whole way inferiorly to the floor of the nose, you can touch it with the tip of the hook, pull the Rittling probe back some, advance the proline, and then bring it out with the hook. In patients who have a nasolacrimal duct that's impassable, you need to move to more invasive surgery like a dacryocysto rhinostomy,